Hello and welcome to the Brain Matters podcast, brought to you by the Florey Institute, Australia's largest brain research centre. I'm your host, Dr. Shane Huntington, and together we'll be exploring the fascinating world of brain health. We'll meet leading doctors and researchers and learn about the reality of a range of brain and mental health conditions from people with lived experience and their carers. In this episode, we'll be exploring brain cancer. Primary brain cancer affects almost 2,000 Australians each year, and despite significant research efforts, the disease remains incurable. In this episode, we explore how neuroscience, the study of how the brain works, might help improve outcomes for brain cancer. And we'll hear about research underway at the Florey into how neurons and brain cancer communicate. Joining me today to discuss this important area will be Professor Lucy Palmer, head of the Florey's Neural Network Group. Lucy is leading fascinating research to investigate brain cancer using live brain tissue samples obtained from generous brain tumour patients. We'll also hear from neurosurgeon Professor Kate Drummond, who is Director of Neurosurgery at Royal Melbourne Hospital. Kate is a pioneer in brain tissue collection for brain tumour research and clinical trials. In 2019, Kate was awarded Member of the Order of Australia for services to medicine, particularly in neuro-oncology and community health. And we'll meet Janet Micaleff. Since Janet was 16 in 1984, Janet has had 8 surgeries to remove tumours, but they keep returning to her brain. With such a long history of living with this uncertainty inside her head, Janet has become a voice for a community of people in similar situations. Welcome, Lucy.
Thanks. Great to be here.
Welcome, Kate.
Thank you for having me.
And welcome, Janet.
Hi, thanks.
Kate, I want to start with you. Can you give us a bit of a definition, if you will, of what we mean when we say brain cancer?
Yeah, so cancer is really a definition of what we see down the microscope. So we take out a specimen, we look down the microscope and we say, this looks like cancer because the cells are very abnormal, they may be able to travel to other parts of the body, they look very disordered. And that definition fits really well for most types of cancers. The problem with brain cancer is that even if something isn't technically cancerous looking down the microscope, if it's growing in the middle of your brain, it's pretty much like cancer for the patient. So we often use the term brain tumours, which encompasses that whole range of even things that are technically benign but really affect the patient a lot, to the slow-growing cancers and right up to the really fast-growing cancers where patients are likely to live less than 12 months. So it's quite a range, and there's probably 200 different subtypes of things that can grow in your head.
Right. And in the case of the brain, do we ever get the scenarios like we have with blood cancers and so forth where it's distributed, or is it always kind of a solid mass or a specific sort of physical part that's sort of, in one location?
It can be everything. So it can be a solid mass growing on the coverings of the brain. It can be a really rapidly growing cancer that is just displacing and destroying the brain around it. Or it can be a slow growing cancer where really brain cancer cells and brain cells, normal brain cells, are completely intertwined and in the same place.
Right.
So it's all the things. The most common cancerous one is a lump that just destroys and invades the surrounding brain, but we have all of those other types. And, of course, cancers like breast cancer, lung cancer, bowel cancer can go to the brain, and they grow as a lump, just displacing the rest of the brain.
Yeah. And what tools do you have at your disposal currently to address this? Obviously, you're a surgeon, so there is the cutting aspect, but what else can you do?
Well, we've got a pretty limited toolbox, to tell you the truth. Surgery aims to firstly make a diagnosis. So sometimes it's just a biopsy to get a piece of the tumour and make a diagnosis. But in general, we would say that removing as much of the tumour as is safely possible would help patients. But safe is the big word. You can't always remove tumours in certain locations because you'll disable the patient. It's not like amputating a leg so that you can get the whole thing out but the patient can go on. Then the next step's really radiotherapy. Again, that's basically X-rays that damage the genetic machinery of the cell, and that can be given in various ways, and we've got some very fancy pinpoint ways of doing that. And then drugs, which used to be standard chemotherapy. That's basically a poison that kills a cancer cell because it's growing faster than the brain cell. But now we've got some things called targeted agents, which are a little more selective in their effects on the tumour cells rather than on the brain cells. But in each case, you've got brain cells and tumour cells next to each other, and you've got to try and kill one and protect the other. And that is one of the reasons why it's such a tricky problem.
Yeah. Now, Janet, you are in the category that I think Kate sort of mentioned, which is you've had tumours during your life. Your first tumour was when you were 16. What were the signs that this was happening? How did you know?
I had no symptoms. I just happened to – I was on school holidays with my mum, went to optometrist, and my optometrist, Mr. Jennings, said, I've got some time to see Janet. And I was like, I just want to go shopping. And anyway, he did an eye test, and this is back in 1984. So then he sent me over to Nauru House to an ophthalmologist and further tests. And next thing we know is I've got an appointment to see a neurosurgeon in Victoria Parade, Fitzroy. And so we went to the appointment. Mind you, there was no Google back then. So my mum and I, we went to Myers, we had a coffee, and there was a dictionary through the bookstore. So I looked up neurosurgeon, and it said, doctor of the nervous system, central nervous system. I went, there's nothing wrong with my nerves, so this is just a waste of time. Anyway, sat in front of Mr. Petty, and he had to put the CT scan, because there was no MRI then, against his window, because there was no computer there. And he was telling me, and I had a voice. I was very quiet, but I said, I don't think you've got the right person. I don't have any symptoms. And he said, well, how did you get here? I told him about the optometrist. He said, well, that's a pretty good optometrist to get you here. Because the tumour was in the third ventricle of the brain, so it's right behind the eyes. So it's like a straw, and it was starting to constrict. And he said if he had known with MRIs, he would have sent me straight to the hospital and he would have operated that night. But I got in a couple of days later. He put a shunt in the back of my head to drain the fluid, operated a couple of days later to remove the tumour, tested it in pathology in the theatre saying it was malignant, so I got sent off to Peter Mac to get some radiation. Then they said to me, no, you've got to go back to see your neurosurgeon. And I'm like, oh. So then he told me usually the pathology tests in the surgery are pretty accurate, but it's come back that it's benign. And I'm 16 going, what's benign? What's malignant? Like a real idiot. And he goes, it means that it's not cancerous and we've got to go back and operate. So I had 3 operations within 10 days in that period of time.
That's amazing. There's a bit to unpack there. I mean, first of all, you were talking about CT scans. So, I mean, this was before MRIs.
Correct.
Or in those days, they weren't called MRIs. They were called nuclear magnetic resonance imaging systems, but no one wanted to put their head in something with the word nuclear on it. So we renamed those. As a physicist, I was less concerned, but I can understand where that come from. Kate, when you hear this and you hear about this tumour, this is obviously still growing in the brain, so causing, at that point, not causing symptoms, but presumably it would have.
I mean, why did you go to the optometrist, Janet?
Oh, my mum went to the optometrist every year.
So you'd had no headaches?
No. I was just sitting in the waiting room and Mr. Jennings, I still see him today. Mr. Jennings come out and he's gone, I haven't seen Janet for a while. I've got some time. I'll see you. And I'm going, I want to go shopping. It was just a pure coincidence. Otherwise, Mr. Petty said I would have collapsed on the street.
You must have been – so what she must have had is papilledema, which shows pressure behind the eyes. And, this tumour was growing that it compressed the third ventricle, leading to something called hydrocephalus. And that's right, you would have suddenly collapsed and become unconscious sometime in the near future. So that's it's kind of amazing.
Yeah. Now, Janet, this is surgery 1 for you, and you are now similar age to me, so you're in your early 50s, and you've now had 8 surgeries.
Correct.
How often does this come up?
Well, it was like a 7-year itch. Right. It happens every 7 years. So, and there was no rhyme or reason with it, I'd say, to all my neurosurgeons, because they retire on me. And I would say, what do I have to do to stop them? Because once they go, like, you remove them for surgery, I get more coming up. So we're always on wait and watch. But I got told there's nothing that we can do. Like I said, do I have to give up coffee? Do I have to give up sugar, cakes? Tell me what I have to do. And for especially Prof K to say to me, we don't know why you grow benign tumours. We don't know the reason why. I'm sure that was a hard statement for him to say. He does not know. I don't think that's in his vocabulary, but it just goes to show that we just need more research into why this happens. And there is no family history, so there's nothing hereditary or anything like that. And I've had 2 children, and there's no, so it's not history, no.
And during that period of, we're talking about quite a protracted period of, 4 decades or so.
Mm-hmm.
Were there any symptoms during that time, or were they? You've obviously been going back for routine scans, so presumably they're being caught before it causes you any problems?
Yep. I've had no symptoms, no headaches, nothing, no symptoms at all, no. And over the years from 1984 to today, the way it's treated is so much better. Like originally I had the stereotactic halo screwed into my head. Yeah, so. Yeah.
Very different, yeah.
Yeah.
Kate, how common is this sort of tumour relative to the other brain cancers that you deal with?
Well, the tumour that Janet has, meningioma, is actually extremely common. It's one of the more common, particularly in women. But the behaviour of her tumour, which is what I was talking about, a benign tumour that behaves in not a benign way for the patient, that's really less common.
Interesting. Now, Kate, one of the other things that you very kindly do as part of your services help procure tissues for the Florey and for Lucy, who we're going to speak to in just a moment. But what's involved in collecting tissue in that way and making sure it's viable for use in the lab?
Yeah, well, it's not kind of me. It's kind of the patients.
Okay, yeah, of course.
And, over many years we've developed a system where everyone who's going to have something removed from their brain or their spine is asked their consent to collect their tissue, their blood, sometimes other body fluids, and their data for research. It is extremely rare that patients don't consent. And in sometimes they're like, why are you asking me? Of course, I've got a brain tumour. Please do research. But we've done that over a long time, and that goes to various places. So some of it, like the research I'm doing with Lucy, goes fresh, gets run across the road. Right. Live brain tissue goes across the road with brain and tumour mixed in. Some of it might be frozen for future research. Some of it might go and have a cell line or some other sort of research or done out of it, or put in a mouse, for instance. So it all depends on what projects we've got going on. But we've got thousands of specimens over the years that we've either banked or used, and it's one of the most valuable resources. So any surgery that I do, I'll probably have a few little people standing behind me with little vials, and some of them will need this particular piece of cortex that gets taken out, and obviously cortex we were going to take out anyway, taken out and dropped in a little vial, and someone else is waiting for a piece from the middle of the tumour, and so we sort of work out what we're going to do, and off we go. Amazing.
Lucy, are you the one who runs across the road, or is that you got someone doing that for you?
No, so that's people in the lab. Yeah, they're faster than I am.
They're faster. How do you? I have this image of the surgeon sort of pulling it out and then dumping it in the vial. But how do you keep it alive at that point? Like, what's required?
Yeah, so we just have a little vial that has what we call artificial cerebral spinal fluid. So it's just a mixture of we try to replicate the brain fluid, and we just plop it into that, and then we literally, in an ice bath bucket, and then we literally run it across the road, because we're lucky in that the lab is just, within a 3-minute, run from the operating theatre. Yeah.
And then how do you maintain that? Because presumably a lot of the experiments which we're going to come to that you do require the brain tissue to be active. So how do you keep it alive? I mean, one of the things I always imagine is this stuff dies pretty quick outside the body. So what do you do to keep it alive?
Yeah, so there's a whole procedure to do that. We try to keep it cool, and we also oxygenate it. Oxygen is very important. Also cooling it down, and then when we go to do the experiments, then we heat it up to be more at the physiological conditions.
Right. Now, tell me a bit about these experiments, because you've got various types of tissue. You've got tumour-type tissue, cancer-type tissue. You've got actual brain tissue. Yep. First of all, how do you tell them apart? Are they easy to tell apart?
Yeah, so we use an optical methods where we plop the tissue underneath the microscope, and then we're able to actually visualise what we're looking at. So we can easily visualise a neuron from a glioma cell and all the different types of cells within the brain. So we use something called differential interference contrast, which just enables us just to look essentially on the computer screen, so we can really target the cell type that we want to do our recordings from.
Yeah, and the glioma cell there, that's the cancer cell itself. Yeah. So how is that different to the rest of the brain, like in terms of its cell structure and so forth?
Yeah, it takes a little bit of time to kind of what I call get your eye in order to be able to visually identify it. And we also do other ways of identifying after we've done the recordings. But they look different. They're smaller cells. What I guess the thing that we know most about are the brain cells, the pyramidal cells. These are ones that are the larger cells in the body, and they have a very particular morphological structure that we can really easily identify, especially if it's in the cortex. We can see, what the cell type is, where it is in the cortex, and then we're able to kind of contrast that to the other cell types that we don't usually see in the cortex. So we know that these are probably infiltrating cells, unusual cells, so then we'll target them. So they're most probably the glioma cells.
Are they similarly easy for you to see, Kate, when you're in there?
No, I got nothing. So, that's one of there's a few methods we can use to visualise. So we can give a drug called 5-aminolevulinic acid, which is a drink that the patient has about 3 hours before surgery, and that for certain tumours, it gets into the tumour cell and it glows pink under blue light. So there are some operations we can do. Some of us are old enough here. We call it the blue light disco operation, because we're in the blue light room and we can see the tumour glowing pink. That doesn't work for all tumours. That's helpful, but it's not for individual cells. It's for the bulk and the edge. But most of the time, we really can't tell exactly where the edge is. And we sometimes do surgery awake. So if we're deciding to try and go as far as we can to get as much of the tumour out as is possible, that's often limited by function. So sometimes we'll do the surgery awake so that we can map where the functions are for the patient. We stimulate the brain with electricity and say, okay, speech is here and motor's here, so don't go there, but we can go as far as here. So we've got methods, and there is stuff that's not available in Australia yet, but Raman spectroscopy, which probably is going to be very helpful to look how much cancer there is in the edge of a specimen. But yeah, I'm just doing my best to work out how far I can go without hurting anyone.
Yeah, indeed. Janet, have you been awake for any of your surgeries, or have you been lucky enough to be asleep?
No, I think I'd talk too much.
I think they want you to talk.
Yeah.
Lucy, so you take these samples, you've got them now. Does the cancer part of the sample grow in the dish differently to the rest of the sample?
Yeah, so what we do is we take the actual tissue. We don't really grow it per se, but we just keep it alive so that we can record from the neurons and the glioma cells while they're actually within the brain tissue. And they're able to stay alive for up to 24 hours, sometimes 48 hours, and so we can do recordings all of that time.
Right. Now, one of the things that we had in the intro to this episode, which is just a sort of wild idea, is that some of these cancer cells are actually communicating potentially with the brain cells. And this is not something I've heard before in my many years of doing these sorts of interviews. Talk us through what's happening there, because this seems to be unusual given this foreign element of what's growing in the brain that's not participating presumably in the brain's function typically, but maybe.
Yeah, so that's the premise of our research, is to really understand how the cancer cells kind of go in and interrupt normal brain function, the functioning of neurons. So what we do know from some great studies 5 or 6 years ago is that neurons themselves, so brain cells, actually communicate directly with the cancer cells. So they form what we call a synapse, like a bona fide communication stream, which is normal within the brain. So that's how the brain communicates, how normal brain cells communicate with each other. And now they're forming these exact same communication streams with the glioma cells, the cancer cells. We don't know too much about it, especially in the human case. So that's why we're directly, trying to probe why. But what we do know is that most probably this communication stream results in proliferation of the glioma. So it's this awful vicious cycle where the brain cells communicate with the cancer cells, cause the cancer cells to grow more, and then the cancer cells themselves almost feed back to the brain cells, cause them to be more active, and that causes this awful cycle of proliferation.
So would the cancer cells not grow without that kind of prompt from the rest of the brain?
I don't know fully the answer to that, but that I would say that the brain actually is modulating the rate that it grows. And we do know that for sure from our studies and other studies, that the more active that the brain is, so the more that brain cells are communicating with the cancer cells, the more the cancer cells will grow.
Interesting. So I've got a million questions now because this is wild stuff. Does that mean that cancers grow at different rates in different parts of the brain because of various levels of activity?
Well, that is exactly what we're trying to look at. And so what we can say for now, so we're looking at the cancer growth through the cortex. And what we do see that even within the cortex that there are different rates of cancer cells that can grow through. But this is a question that we're all trying to understand. So,
do you see that, Kate, when you're having repeat patients come through that in various parts of their brain, you're seeing some more often than others depending on where their cancer occurs?
I think that's quite multifactorial. So there's the electrical piece, that the cancers respond to electricity. That's not been really thought of before, but really makes sense. But also the tumour cells often have a preferred substrate for growth. So gliomas tend to like to scoot along white matter. So rather than growing in one direction, if there's a path of white matter where they can go along, then they will. In Janet's case, her tumours like to scoot along the dura, which is the coverings of the brain. But they're, highly unlikely to scoot through the brain itself. So different tumours have different substrates. And then there's sort of just a bit about space. You've got a great big fat frontal lobe and there's plenty of room to grow in there. You might have something in an area that's a little bit more constrained, and that simple thing may actually change, rates of growth or time of presentation. So it's multifactorial as to, what happens with these tumours.
So, Lucy, when we talk about this scenario between the cells, and as Kate just said, we're talking about electrical interactions, these are moderated by our brain cells. That brings in a whole different approach, presumably, to brain cancer, because we have our surgeons, we have our oncologists, we have radiation therapy, we have, for other cancers in the body, we have immunotherapies, and, we have some drugs. The blood-brain barrier makes a lot of this stuff a lot more difficult than it is in the rest of the body. But this is the area of neuroscience. This is, how the brain functions and so forth. So what does that open up for us in terms of potential treatment or understanding?
Yeah, it opens up a whole new world, basically, of potential treatment. We first have to understand exactly the communication streams and what changes in the brain cells and in the cancer cells due to this communication between them. But it does open up new targets, like brain cancer survival rates haven't really changed to the extent of other cancers, and that might be because of the brain being a substrate. So the more that we can understand this, the more that we'll be able to hopefully target different targets, the normal brain cell targets.
Presumably we can't turn the electrical signals off. So what is in the toolkit given that limitation?
So, well, this is where we bring in our neuroscience knowledge. So we know a lot about ion channels, so the parts of brain cells that are really causing communication where chemicals can flow into the brain cells. And so we're really trying to understand the actual synapse of this communication stream, what channels are being affected in there, and maybe hopefully we can really target what is changing in the case of brain cancer, and then somehow being able to target that without really affecting the function of the brain. And that's something that we're really looking at. Using a mouse model, we're also looking at cognition and how that changes with cancer growth.
Yeah. Does this change the way you do imaging as well? Because, you can do functional MRI imaging where you're watching the brain actually operating. Can you, maybe this hasn't been done yet, but presumably if there's this interaction that's real-time interaction between our brain cells and these cancer cells, that sort of functional imaging would provide you with a new level of information that previously has been more sort of structural examination, I suppose.
Yeah, so that's another stream of the research that we do in my lab using a mouse model is that we do use something called two-photon calcium imaging, which enables us to look at activity in brain cells and changes in activity according to the fluxes of calcium, which is a proxy for voltage. So we can look at and kind of compare as the gloma is coming closer to neurons. We're able to in real time image, but different type of imaging to what you were describing, more of the microscale, more at the cellular level, and see the changes in neural activity. So that's another stream of research that we're currently doing.
Now, this may be a question sort of we need to ask in 5 years, but do we have a feeling for why our brain is doing this? It seems like the cancer is a problem for us. And, in an evolutionary sense, it shouldn't be there. But, we get cancers in our body all the time and our immune system clears them, But in this case, something's gone astray. But the brain's actually promoting the growth. Is there any sort of hints as to why that might be the case?
Well, that's what we're trying to really understand. And I always think of it as the cancer almost hijacking the normal brain function. So it really is integrating into what we call the neural networks, just the normal brain function, how the brain normally acts. And cancer is hijacking that system and making the most of it and making it work for them.
Now, cancer throughout the body is very good at this hijacking role. It's good at hiding from our immune system. Is cancer in the brain different in that regard, like to be able to do this very sophisticated electrical hijacking? Yeah,
it is very sophisticated and also infiltrates very well. So, other cancers can be more of a mass-like and stay kind of more together, whereas in the brain it really does send out, the gloma cells can individually infiltrate the brain, which really makes it hard to target because it's really intermingled with normal brain cells than with the cancer cells, which makes it that little bit more challenging to target essentially.
Now, Janet, you've been doing a lot of work in the community around brain cancer and tumours and so forth. This is something that I suppose you have a unique capability there because you've been dealing with this for decades, whereas, as Kate rightly said, the survival rate for, many people with brain cancer is, not great and relatively short. Tell us about those activities that you've been doing and how you go about supporting people with these conditions.
I do it two ways. Some people don't like coming to a support group, so I'll meet them for a coffee. But also to getting people together and seeing other people in the same situation as them, and they can talk to them on a different level to their family and friends that don't sort of understand or they don't want to tell them too much. So they get to ask them questions like, what sort of symptoms are you having? What do you do for that? And so people suggest different things for mechanisms to cope. Like we also suffer from short-term memory, forgetting things. So use your phone to put notes in and stuff like that to keep to remind you, reminders to make sure that you do something. So just little tips and tricks and stuff like that. But just for people to go, there's someone else out there like me. I'm not alone, because people think they're alone because people don't understand. Yeah, and they don't want that look, that sympathy look.
Right.
Or that, they just, so, and just some of the symptoms that people suffer with, like fatigue is a huge issue. And a lot of people think, just go to bed early one night and get a good night's sleep and you'll be right. It doesn't work like that. Fatigue is just something. Some people call it brain fog, but it's just you just feel like you're in, not like when you're driving a manual. You're stuck in second gear, just won't go into third. So and it's just like-minded people getting together and just feeling a little bit normal and in a safe space to talk that and suggestions from other people about how to get over those sort of barriers to help them.
Yeah. Kate, from your perspective, how important are these groups? You have a very technically, difficult job to do, and you obviously don't have a lot of time to, I think you're better in the surgical suite than spending your time, going out and talking to vast numbers of people about the work. There's very few neurosurgeons with these capabilities around, I suppose, in terms of need. How important are groups like the ones that Janet interacts with in terms of supporting your patients?
So I'm going to disagree with you there.
There's many neurosurgeons?
No, we're a limited resource. However, I just gave a talk this morning to the American Association's Joint Section on Tumours about quality of life in brain tumour patients. It's more than walking and talking.
Yep.
Which, of course, neurosurgeons are like, you're walking, you're talking, you're doing great, but the patients don't feel that way. And I think that if we spent as much time on managing the quality of patients' life as we did the quality of their surgery, we would actually revolutionise our treatments, because I think the patients would do better. The problem is we have this nebulous group of symptoms that doesn't matter what sort of brain tumour you've got, everyone complains of. Headache, sleep disturbance, fatigue, anxiety or depression, and all of those things are almost universal.
Yep.
But if you come to my very good multidisciplinary outpatient clinic at Royal Melbourne Hospital, no one is going to ask you about your fatigue or your sleep or your anxiety. And I think that we really, really dropped the ball there. And so these groups are super important, but they're quite limited because they don't reach rural patients. Mm-hmm. And, no one has their brain surgery in Albury. They come from Albury to have their brain surgery here, so they can't really attend. Many patients can't drive because of either their neurological deficit or they have seizures. So those patients are often out because navigating complicated public transport is difficult. And sometimes it's quite confronting to be in a room with people who have a life-limiting diagnosis. So I think we need to find better ways to do this. One of the things that we're developing, and I'll give it a plug, is an online support platform that's just come out of research mode and gone for public consumption, called Brain Tumours Online. So that you can Google that. That is an Australian website that has information and tools to cope, and a social media online support community. But this sort of support is vital, but it's limited in one way to the people who can access it and who feel comfortable accessing it. So we need to do better.
It's certainly that more holistic view of healthcare is one that we're starting to see in some areas, around women's health, around endometriosis. It's being acknowledged that there's got to be more than just surgery. But are we seeing that in other areas of cancer at all, or are they all equally sort of a bit behind in that space?
Oh, no, I think, the more common and the more, I hate to say this, but the more well-funded cancers do it a lot better. Breast cancer, is much more advanced in this sort of idea. So I think it's there, but it's very difficult. It's labour intensive. How much allied health do we have? How many psychologists do we have in a public hospital? One thing that we've looked at is using machine learning to predict in advance which patients are most likely to have reduced quality of life at 1 year, so that we can help maybe target early interventions for those patients. So I think we could be a bit smarter about it.
Lucy, in terms of the research, is there similarly resource constraints for brain cancer research compared to other cancers? We've seen incredible sort of changes in the way cancers are treated in many parts of the body over the last sort of 3 decades. And yet it seems as though, we're still a fair way behind with brain cancer.
Yeah, I think there's always constraints for funding for research, and I feel like we're just at the starting point basically in research into brain cancer, in the sense of really trying to kind of bring the brain into that type of research. So there is you can only do as much as the funding allows you to. So there's always need for greater funding, because it really does help in our understanding.
Where would you head if you had that funding? If the big bucket turned up tomorrow from wherever, what would be the next thing you would sort of go after in this space?
Yeah, it would be like very much, since we're doing recordings from living tissue, it really is the numbers of hands that are able to actually perform the experiment. So it really is kind of replicating what we have. We've got this, it's taken us many years to develop this, really quite sophisticated pipeline, and it literally is just trying to get more people involved in the research and getting out there and talking more about the research. So it would be very much more hands doing the research, and also using very more advanced techniques, because techniques are improving, annually almost in neuroscience research.
Yeah, I wanted to ask you about that, because we spoke earlier about how the material is run across the road. You're very fortunate to be so close to the hospital where the surgery is occurring. But are there limitations in terms of the number of people you have to do the experiments before that tissue starts dying? Like, is that a constraint?
We've got wonderful postdocs in the lab, so we have 3 people who do recordings. It's very sophisticated equipment that we use as well. So it's the people, but it's also we do something called patch clamp electrophysiology, which has a whole rig associated with it. That is a constraint, because the more people that you have to do the recordings, the more recordings that you'll have while the tissue is healthy.
And when you're recording this material, like, how physically big are these samples? Like, is this the sort of stuff that is really hard to deal with, or is, are they centimetres, millimetres, microns?
It really depends on what's possible, basically. So we try to do the recordings, very precious tissue, very precious recordings. So we try to do recordings from whatever size of the tissue that is able to be safely removed from the patient. So we slice them up using a vibrotome into smaller sections. So we have a standard procedure. So,
and when you say recordings, you mean recording electrical signals between the individual cells or groups of cells?
Yeah, in the individual cells. So using this technique, we do this patch clamp electrophysiology, which won a Nobel Prize, a couple of decades ago. And it's a very precision technique where you record the electrical activity directly from a targeted cell. So we're able to visualize the cell on the microscope, and then we go in with this small pipette that has about a 1 micron tip, and that we penetrate individual cells and then record the electricity within the cell of target. Yep.
Right. And then you can presumably see the sort of that circular interaction between the cell, so the glioma cell, and the neural part of the brain, and you can see that back and forth going on.
Exactly. So then we're able to look at the synaptic responses within, to say, the glioma cell, or we're able to look at the neural activity within the principal neurons, the brain cells. So we know a lot about brain cells and how they normally act, their voltage responses, and so we record the voltage responses and how they differ from in the different cancer and tumour types, and then we're looking to see what these voltage responses or this communication synaptic responses look like in the cancer cells. We're currently characterising that, and it really gives us insight into the ion channels and the particular streams of information, basically the information that the brain cells are sending to the glioma cells.
Does this mean we'd sort of be targeting a completely different sort of set of drugs and type of drugs to deal with this problem if you know that those channels are in particular what is an issue? Because when Kate was talking about chemotherapies earlier, it's faster growing cells that are killed first. So it's essentially a poison. But this presumably would be a lot more targeted?
Possibly, but we're a long way away. So, in this instance, we're really trying to understand it and then hopefully open up new avenues for different approaches. Yeah.
Yeah. Janet, when you hear all this, obviously you don't have cancer based tumours per se, but as Kate rightly pointed out, the difference is kind of in the noise in a sense, because these tumours can still be life-threatening and problematic for you. What's the future hold for yourself in terms of what you have to do next? Are you getting routine scans? Like what's the scenario?
Yeah, I have routine scans. I'm just going to yearly now, which is exciting. But I'm excited, I just want to say, when I hear talk like this about research going on and advances and stuff like that. So I get excited because I think that's good. And, yeah, I mean, as we're saying about types of cancer and tumours, I could have a benign tumour in my brain and it could be inoperable. So it doesn't really matter if it's cancerous or non-cancer. If you can't get it out, I'm in, a bit of trouble. But my hands are in these guys, so I'm very fortunate. So, no, I'm very excited about the future. A lot more happening.
And you must have seen like the difference in the way you get your scans done. I mean, I'm sure your original scans took a long time compared to, some of the fast MRIs now. You're in and out in probably 7 to 12 minutes or something.
Correct, yep. And now they're on a computer screen. I can see it. I don't have to put it up against a window, and carry the scans with me,
Yeah. Kate, has that affected what you can do? Because you must have incredible imagery now available to you to determine exactly where you are in the brain, and presumably even some of it's while you're operating, is that right?
Yeah, I mean, the quality of MRI is amazing. I remember we used to call them EMI scans, EMI, because that was the company that made them, and the Children's Hospital had the EMI scan, which basically looked like a pixelated blob. But anyway, that was, and MRIs now are, they're extraordinary. You get down to the 7T MRI, and it's just, amazing, the structural detail that we get. We have lots of different sorts of imaging, but we've got an intraoperative MRI. So we operate on the patient, and behind my operating theatre there's some acoustically shielded doors. We sort of leave the patient's head open and wrap them up in a particular way. The doors open, we dock them into the MRI, which is in the next room. We take the pictures and we say, oh, there's a bit we didn't get, or whatever, and then come back in and update the imaging that we have. We have navigation, so all surgeries are done with navigation, which is where we register the patient's preoperative scan with their head in 3-dimensional space. So wherever I put my little wand, I can say that's where the tumour's going to be. And so for someone who, like Janet, who might have, multiple tumours and we're trying to just target one, we can make a very small hole directly where we wanted to go because we've got this navigation, which, when I was a trainee, basically we took off the side of the head and we poked the brain until we found the soft bit or the hard bit, and that's where we did the operation. So, it's completely different to what it used to be.
Yeah. Are you finding some of the new sort of AI technology in that coming into play at all in the surgery suite, or is that sort of still sitting outside in terms of the determination of what's in the imaging?
It's starting. AI is built into navigation now, but I don't think it's made a massive difference for us. I think AI for making decisions on imaging is, training it on thousands of scans or millions of scans has really started to come in, and certainly in pathology where, they're looking at pictures and really classifying them. So those things are coming, but it'll be a big part of it. Yeah.
Typically, how long does it take you to do one of these surgeries? You've done surgeries on Janet. What's the time frame?
It's very variable. So a 2-centimetre lump over the surface of the right frontal lobe or in the right frontal lobe might take 2.5 hours, and a nasty meningioma down in the, what we call the petroclival region at the back of the brain could be 12, 14. My record's 18 hours.
18 hours. Is there like CrossFit or something? How do you train? I've always wanted to ask you, how do you train to stand by the bed and do this incredibly detailed work for 18 hours?
Oh, you train. It's like anything. I don't know. How do you become a Swiss watchmaker, or, how do you play with the Matildas? You train.
Right. So it's not all.
You do have assistants. You do go and, have a cup of coffee in a Mars bar and go to the bathroom. Like you have to. It's not. But it gets harder as you get older.
Right.
End of a long day of operating, it's like, okay, I need to have a cup of tea and a lie down now.
Yeah, look, I think it's amazing. It's one of those areas where obviously, the research is so important because, the ability to do these long operations, and that is, it takes an incredible degree of skill. Some of them, as you say, are inoperable. So alternatives have got to be viable. It was interesting how you described the way the tumours can grow. I think a lot of people probably have this image of just a lump, but it sounds like it almost like spiderweb through the channels of the brain. Yeah.
Yes, very much like that. But you're talking about me doing long surgeries. Lucy's lab. The postdocs and the PhDs, if they get a piece of tissue from me at 4 or 5 o'clock in the afternoon, they're patching until 3 o'clock in the morning. Right. So, it's a marathon for everyone here.
Yeah. Lucy, in terms of the research, what do we know now? Like, how much information do you have at this point? Because this is it's always interesting when it's an exciting new space because there's probably more questions than answers. But what are you sure about at this point?
What we are sure about now, and so I would say that now is a really exciting time to be doing this type of research because we do know that the brain is influencing the cancer growth and that the cancer is essentially hijacking and taking over normal brain function. So we know that, but we don't know how it's doing it. So that's what the future will hold. We're going to catapult into really truly understanding how the cancer is really hijacking the brain and to really try to understand how we can try to stop that and try to prevent further proliferation and effects to the brain.
Yeah, amazing. Lucy, thanks for being on the podcast today. I hope we have this discussion again in 10 years and things have just exploded in terms of where this has gone because it is an exciting new space that you're working in. Thanks so much.
Great. Thanks for having me.
Janet, 8 tumours down, hopefully no more for you.
Touch wood.
Yeah, great hearing about your story and that long period of dealing with this ongoing problem and all the support that you give to others. Thanks.
No, thanks. Thanks for the time.
And Kate, I think we should send you back over the road. I'm sure you've got important surgeries to do and it's good to know that you're there taking care of people in need.
Thanks for having me.
God bless you guys.
You've been listening to the Brain Matters podcast, brought to you by the Florey Institute of Neuroscience and Mental Health. Join us for our next episode on brain health, and if you have a particular topic you would like us to cover in the future, please drop us a comment or send a message via the email in the show notes. I'm Dr. Shane Huntington. Thank you for listening.